Welcome to the Certificate Program in Nursing and Nutrition, or CPNN. Today, we will cover the module entitled Bridging the Nutrient Gap in Preterm Infants. On completing this module, participants will be able to understand the nutrient requirements of preterm infants, discuss various aspects of human milk fortification for preterm infants, recognize preterm formula as a breast milk alternative. Let us begin by discussing nutritional needs in preterm infants. The on-screen table displays the enteral fluid and macronutrient intake for preterm infants recommended by the American Academy of Pediatrics and European Society of Pediatric Gastroenterology, Hepatology, and Nutrition. Both recommendations suggest similar fluid, energy, and macronutrient intake. 130 to 200 milliliter fluids per kilogram body weight per day, 110 to 135 kilocal energy per kilogram body weight per day, 3.5 to 4.5 grams protein per kilogram body weight per day, 11.6 to 13.2 gram carbohydrate per kilogram body weight per day, and 4.8 to 6.6 grams fat per kilogram body weight per day. The enteral vitamin intake for preterm infants recommended by the American Academy of Pediatrics and European Society of Pediatric Gastroenterology, Hepatology, and Nutrition is displayed on the screen. The recommendations for fat-soluble vitamins are similar. For example, 400 to 1,000 micrograms of vitamin A per kilogram body weight per day, 400 to 1,000 international units of vitamin D per kilogram body weight per day, 2.2 to 11 milligrams of vitamin E per kilogram body weight per day, and 4.4 to 28 micrograms of vitamin K per kilogram body weight per day. For vitamin C, or ascorbic acid, the American Academy of Pediatrics suggests 20 to 55 milligram per kilogram per day, while the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition recommends 11 to 46 milligram per kilogram per day. The enteral intake of B vitamins for preterm infants recommended by the American Academy of Pediatrics and European Society of Pediatric Gastroenterology, Hepatology, and Nutrition is displayed on the screen. The recommendations for B-complex vitamins are similar. For example, 140 to 300 micrograms of thiamine per kilogram body weight per day, 200 to 400 micrograms of riboflavin per kilogram body weight per day, 45 to 300 micrograms of pyridoxine per kilogram body weight per day, 0.1 to 0.8 micrograms of vitamin B12 per kilogram body weight per day, and 1.7 to 16.6 micrograms of biotin per kilogram body weight per day. In the case of niacin, the lower end of the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition recommended range is slightly lower when compared to that recommended by the American Academy of Pediatrics. The enteral mineral and electrolyte intake for preterm infants recommended by the American Academy of Pediatrics and European Society of Pediatric Gastroenterology, Hepatology, and Nutrition is displayed on the screen. The recommendations for iron, iodine, sodium, and chloride are similar. For example, 2 to 3 milligram of iron per kilogram body weight per day, 10 to 55 micrograms of iodine per kilogram body weight per day, 69 to 115 milligram of sodium per kilogram body weight per day, and 105 to 177 milligrams of chloride per kilogram body weight per day. However, the upper end of the American Academy of Pediatrics recommended range is slightly higher for zinc, calcium, and potassium when compared to that recommended by the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition. In this section, we will understand the various aspects of human milk fortification for preterm infants. In the previous modules, we have already discussed that preterm infants have high nutritional needs, as they miss out on growth and nutrient accretion during the last trimester of pregnancy. While human milk offers several benefits to preterm infants, it is important to note that human milk alone does not provide sufficient amounts of several nutrients for premature infants when fed at usual volumes. Thus, it is a major challenge to meet the high and variable nutrient requirements of preterm infants during hospitalization. Let us compare the requirements of energy and protein for preterm infants and the amounts of these nutrients provided by human milk, which varies based upon the volume of mature human milk. The American Academy of Pediatrics and the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition recommend 110 to 135 kcal per kilogram per day energy and up to 4.5 gram per kilogram per day of protein. However, human milk at a lower fluid intake of 150 milliliters per kilogram body weight per day does not meet protein or energy requirements, as recommended by the American Academy of Pediatrics and the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition. This is an issue with infants who cannot tolerate large volumes of milk and in those with fluid restrictions. Even at higher volumes, while energy requirements can be met by mature human milk, protein requirements are not met, even at high volume of 200 milliliter per kilogram body weight per day. The consequences of each nutrient deficiency is different. Any shortfall in protein intake leads to impaired growth, and it is particularly responsible for reduced gain in muscle mass. It is also associated with poor brain development and functioning. Energy also adversely impacts growth and brain development. Other deficiencies, such as calcium and phosphorus deficiencies, can lead to osteopenia or weak bones. While some deficiencies have a lower impact, others, such as protein deficiency, have more serious long-term implications, such as poor growth and brain development. Thus, it is important to meet the nutritional requirements of preterm infants. Human milk fortification, that is, supplementing human milk with certain nutrients, is a strategy that helps to overcome the challenge of inadequate nutrient delivery by human milk. Fortification is needed, especially to meet protein needs. Fortification provides additional protein, calcium, phosphorus, vitamin D, and sodium. The use of human milk fortifiers is now considered standard practice in most neonatal units. The goals of fortification are to increase the concentration of nutrients within the recommended feeding volumes of 135 to 200 milliliter per kilogram per day, to achieve recommended dietary intakes, to support growth rates similar to the intrauterine growth rates. Apart from helping to meet the nutritional requirements, studies have found preterm infants who were fed fortified breast milk put on weight and grew in length and head size a little more quickly while they were in hospital. Improved growth is linked to better brain development and function. As a matter of fact, studies have found that weight and head circumference gains from birth to discharge is related to brain functioning during childhood. Last but not the least, fortifiers also supplement minerals and vitamins such as calcium, phosphorus, and vitamin D. Fortifying the nutrition of preterm infants improves bone health. The guidelines for addition of fortifiers vary among neonatal intensive care units, and implementation is left to the healthcare provider's discretion. Appropriate fortification can be initiated once the infant is able to tolerate human milk enteral feedings of 100 milliliter per kilogram per day, but sometimes it may be started as early as 50 milliliters per kilogram. When using donor human milk, fortification can be started at low volumes, such as at 40 milliliters per kilogram per day. The use of human milk fortifiers may be continued in preterm breastfed infants either to term or around 52 weeks post-conception, according to their growth trajectory. There are various products available for fortifying human milk for preterm infants. Based on the origin of milk, human milk fortifiers can either bovine, human, or donkey milk fortifiers. Human milk fortifiers can vary based on the nutrient composition. They can be multi-nutrient fortifiers or supplements of proteins, lipids, carbohydrates. Human milk fortifiers are available in two forms, powders and liquids. Different types of fortifiers are available that may either contain intact cow's milk protein or hydrolyzed cow's milk protein. Hydrolyzed protein may cause slower weight gain and higher urinary excretion of essential amino acids in formula-fed infants. Fortifiers produced from donor human milk are available at considerable cost in some countries. Addition of these fortifiers allows an exclusive diet of human milk, and this has been associated with less necrotizing enterocolitis, better feed tolerance, shorter length of hospitalization, and cost savings when compared with feeding bovine products. Fortification of human milk is usually standardized. This fortification method is currently used in most of the neonatal units. It involves adding a fixed amount of fortifier to a fixed volume of human milk according to the manufacturer's instructions. While it is practical, it does not always match the nutritional needs of the individual infant. Despite standard fortification, some preterm infants may continue to have suboptimal growth. One of the potential problems is that the composition of human milk varies over the postnatal period and also from mother to mother. Thus, assumed composition may not be accurate. This has led to the suggestion that protein and energy content of human milk should be measured, and based on the results, human milk must be supplemented with additional nutrients. This is referred to an individualized human fortification. While some studies show that this method of fortification has resulted in significant increase in weight and length among preterm infants, more research is required in this area. The use of human milk fortification has not been associated with significant long-term adverse effects. the antibacterial activity of human milk can be diminished by added iron in fortifiers. While some research has found delayed gastric emptying in certain preterm infants who cannot tolerate fortified milk, recent studies have reported that when the recommended concentrations of fortifier are used, human milk fortification may not result in clinically significant feeding intolerance. There is no clear evidence that human milk fortification is associated with the risk of necrotizing enterocolitis. Hence, the healthcare provider can weigh the benefits of growth and neurodevelopment that can be achieved with the help of fortification against the possible risks of feed intolerance and necrotizing enterocolitis. In the last section, let us discuss breast milk alternatives designed for preterm infants. Formulations specifically designed to meet the nutritional needs of preterm infants are called preterm breast milk alternatives or substitutes. By now, we have understood well that preterm infants have higher nutritional needs than term infants. Thus, it is easy to understand that standard breast milk alternatives designed for term infants may not provide preterm infants enough nutrients for optimal growth and development. It is appropriate to use preterm breast milk alternatives if maternal or donor human milk is not available for feeding preterm infants. Preterm infants have a relative deficiency of an enzyme required to digest lactose. Hence, premature breast milk alternatives have a lower lactose concentration than term formulations. Preterm breast milk alternatives generally comprise chiefly whey protein rather than casein. Compared with term breast milk alternatives, the protein content is 50% greater. This helps to improve the weight gain and protein storage in preterm infants. In terms of fat content, preterm breast milk alternatives are almost similar to term breast milk alternatives. The concentration of vitamins is also higher. Overall, preterm breast milk alternatives provide higher amounts of calcium, zinc, iron, phosphorus, and copper than term breast milk alternatives, but they do not exceed recommended energy intake goals. Thus, the composition of preterm breast milk alternatives are specifically formulated for preterm infants and are more appropriate. In summary, preterm infants have high nutritional needs. Human milk alone does not provide sufficient amounts of several nutrients to premature infants when fed at usual volumes. Human milk fortification helps to overcome the challenge of inadequate nutrient delivery by human milk. There are different types of fortifiers based on the origin of milk, nutrient composition, and the form available. Fortifiers are commonly added once the infant is able to tolerate 100 milliliter per kilogram per day of human milk and discontinued when the infant reaches a weight of 2 kilograms. Formulations that are specifically designed to suit the nutritional needs of preterm infants are called preterm breast milk alternatives or substitutes. It is appropriate to use preterm breast milk alternatives if maternal or donor human milk is not available for feeding preterm infants.